Well, good morning, everybody. It's a pleasure to be here in Switzerland. It's my second time. The first time was a conference, but it was some 15 years ago, and it's really nice to be back here. Today, I've been asked to speak about neural inhibition occurring as a result of trauma or disease occurring to a joint. And the pathway that I'm going to take you along today is before you here. Firstly, we'll have a look at what is this arthrogenic muscle inhibition, which I'll be calling AMI, and why is it a problem. And thereafter, we'll have a look at some of the factors that are thought to lead to this inhibition. And then finally, we'll have a look at some of the therapeutic methods that might reduce the inhibition. So some techniques that you might use in your practice to allow you to strengthen your patients more effectively. Well, whether a person is put in plaster or whether they're operated on or whether they have a chronic joint problem, they're going to, in many instances or in most instances, have a decrease in strength. And we appreciate that as clinicians most easily by just looking at the atrophy that we see when we look at a person's limb. But we've got to remember that reduced strength reflects not just atrophy, but also a change in the ability of the muscle or the nerves to turn that muscle on. So if we were to provide a definition for this arthrogenic muscle inhibition, AMI, we'd say that there was marked weakness due to neural inhibition that prevents the muscle from being fully activated. And the source of that inhibition is, in many, many cases, the joint, the damage that's been occurring to the joint. Now, we can appreciate this in the lab very easily by putting electrodes on a muscle of interest, for instance, the quadriceps, and also stimulating those electrodes. And you might ask an individual to do a maximal contraction, and here you see an example of one. And when that contraction is in its plateau phase there, you might turn that stimulator on. Now, if there was no blip at all, that person would be activating all those muscle fibers quite normally. In most instances, we can activate more than 95% of our muscles' fibers. But where there's been damage to a joint or a chronic disease going on which affects the joint, then we can see activation deficits, which can be as big as 20 or 40% in respect to the size of this twitch that you get when you stimulate the muscle when the maximum plateau has been reached here. So why is this a problem? Why would we want to enhance or to make sure that we've got the muscle working at 100%, so to speak? Well, the first reason is that we see at least moderate relationships when we look at the relationship between, say, strength, and we look at a relationship with, in this instance, strength being a 6 RM leg press. So imagine somebody doing a leg press type exercise, and then imagine looking at their hop distance. And the relationship here is positive, as you see. The stronger the individual is, the further they're going to hop. And of course, in sports, that has the potential to be immensely important in regard to performance. We also know from a injury perspective, a more longer-term injury perspective, if you like, that if you have weakness in your muscles, you can change the ground reaction force trace that you generate when you walk. So imagine a person walking over a force plate, and what you're seeing here is two ground reaction force traces. In the first one, which is the greenish color here, you're seeing somebody who doesn't have any problem at all with their quadriceps muscles. And what you will see in individuals who have a weakness of the quadriceps muscles is that you'll often see this transient here. You'll see this increased rate of force development for a very short time. It's a high frequency transient, and that has been implicated in respect to damage to the joint structure itself, damage to the articular cartilage. So another good reason why we might be interested in making sure that the muscle is turning on as effectively as possible. Now, a number of joints in the lower limb are affected by AMI, and I just give you 3 or 4 of them here. For instance, the ankle joint, AMI affects the EMG activity of peroneus longus, so there's the muscle that's affected down there. Also, the plantar flexors are shown to be affected if you have a damaged ankle joint. At the knee joint, it's almost exclusively the quadriceps that's the muscle that's affected, and you'll see changes in torque, deficits in the amount of torque it can generate, and also its EMG activity. At the hip joint, the hip extensors have been shown to be affected, and even if we look into the upper limb, there's work which shows that this inhibition as a result of joint damage can occur to the elbow flexors. So all of the joints, the key joints that are related to shock absorption and function within the lower limb during gait activities are affected by this. What about the time course? When is it worst? Well, various studies have shown that it appears to be worse in the acute stage after an injury or after surgery. And this slide is from the work of Shakespeare and co-workers. And if you look across this axis here, we see that the time after surgery, 2 to 3 hours, 1 to 2 days, 3 to 4, and you can appreciate the amount of quadriceps inhibition on this y-axis that's down here, and it's apparent that it's the first 2 or 3 days where we're seeing the most inhibition occurring, and you've got inhibition up to 80% in the quadriceps over this period of time. And then gradually over time, this decreases. While that might be so, it doesn't keep decreasing in a linear way and go away by itself. And there's data from studies looking at people who have had total joint replacement, for instance, that show that 36 months, even longer, they still have an activation deficit, and that activation deficit might be over 20%. So it's not just an acute effect, it's an effect that can be quite chronic. Now, an important point to recognize is that the activation deficit that you might see in a muscle, for instance, quadriceps, as a result of, for instance, having a damaged knee joint here, it's not exclusive to that limb. It's a bilateral effect. So if we have a 15% activation deficit on the involved side, if we looked and activated the uninvolved side, we would see that it would have roughly around 2/3 of that. So there'd be a 10% deficit there. And here's a group of age-matched controls, gender-matched controls, who don't have any problem at all, and you can see they have very little in the way of a deficit. The take-home point from this one, though, is that you can't use the opposite limb as your reference point. Use it initially to build up strength in that involved limb, but then recognize that you've still got a way to go if that person's got to get back to a performance in sport, for instance, where they've got similar torque or strength levels to their fellow competitors. Now, what is the mechanism? Why is this happening? What's the cause of this inhibition that I'm talking about? This is a conceptual framework of AMI that you see in front of you here. And one of the key points is that we get altered sensory output occurring from the joint. And that leads to a change in the excitability of the spinal reflex pathways. And thereafter, we're going to see a reduction in the muscle's alpha motor neuron excitability. And of course, when that happens, we're going to have decreased muscle activation, or if you like to think of it more simplistically, you're going to have decreased strength. Now, that might seem like a very simple and basic explanation of it. It's much more complex than that, but time doesn't prevent me to get into this slide, which I'm sure you're looking at and going, oh my goodness, I'm glad he's not going near there. But the key point that I want you to recognize is that while I've given you the key stages, if you like, there are a lot of other interactions going on within the spinal pathways and even up here in the brain, which modulate what goes on in the amount of inhibition that we see. And Nicola this afternoon is going to talk a little bit more about that, the cortical changes that we see. So what is the altered sensory feedback that I'm talking about that kicks this off, if you like, or starts the whole process going? The change in discharge to the sensory receptors from the damaged joint. Well, there are a number of factors that can influence that. The first of those is swelling. We know that you can induce, or some of the experiments that I've done, we've put saline and dextrose into the knee joint. You can put as little as 10, 15 mils into the joint and you will start to see decreased activation from vas medialis. And if you go a little bit further and get up to 20 to 30, you'll start to see lateralis kick in the other muscles, etc. If there's also inflammation going on, so this is much more like a real or a true joint swelling after an injury. There's inflammatory products within the joint. Those same receptors, those tension receptors, pressure receptors, which are activated if you put in neutral fluid, they are much more sensitive. They'll be firing off at rest and they'll be firing off at much lower thresholds. Similarly, if you have damage to particular structures, you might damage your anterior cruciate ligament, you might damage the actual receptors within that ligament, and the more damage that you actually have within the joint, the greater the amount of inhibition you're going to see in quadriceps or in other muscles at other joints. And then the final influence is going to be joint laxity. If you've got joint laxity occurring which is uncontrolled, again you'll see more AMI occurring. Now here's a key point for you. Swelling is often apparent for many, many months after surgery, for instance. And here's an example from our anterior cruciate ligament reconstruction. This is from the work of Froebel. And on the x-axis here, you see months, 0, 3, 6, and 12 months post-operation. And here you see the amount of fluid in the joint. And even at 6 months after the operation, we see there's enough fluid in this joint to be causing arthrogenic muscle inhibition, AMI, to the quadriceps. And you have to be cognizant of that in regard to the type of training that you're doing with the individual and how you manage that inflammation if you want to get the most of your muscle program. So on to the final section now. What can we do about AMI? How can we reduce it within the clinic and lead to more effective activation and better strength from the muscle? Well, we can take two approaches. One is to focus on the periphery. Jumped forward. One is to focus on the periphery, the joint itself. And we'll go through some strategies over the next few slides. And then the second approach we can take is to look at the central nervous system, particularly the brain, and Nicola this afternoon is going to go into this in much more detail. So I'm going to be focusing on this first one, the peripheral approaches, over the next few minutes. The first key point is don't ignore it. If you can see a little bit of swelling in the ankle joint or the knee joint, then AMI is going to be present, and you can do a lot of strengthening with that individual, and you will not get the potential gains that you should be getting by just saying, oh, it's a little bit of swelling, it'll be fine. You've got to act upon it and try and reduce that. One of the ways that you can do that is by, firstly, when you start exercising and doing isometric exercises with individuals, if you can choose a point where the articular pressure is at its lowest in the joint, then you're going to be most effective in regard to any fluid that is in that joint. And for instance, at the knee joint here, we can see by putting the joint at around 20 to 30 degrees, we've got very low intra-articular pressure, and as a result of that, those receptors will not be firing off as much, and you'll be able to get better activation as opposed to doing muscle work further into flexion or right up close to full extension. Another technique that you can use in the clinic is icing the joint, but you've got to be a little bit particular. And this is a study that we did 2 or 3 years back where we put fluid into normal knee joints, and we had 2 groups of individuals, and one group of those individuals got ice pack wrapped around the knee joint there, and you can see we've really made an effort to make sure it's just the knee joint and we're not getting ice on the muscle itself. And then we've got another group that had no ice. And what you can see on the slide or this figure on the right here is the improvement of strength. So we might have had, say, a 20-30% AMI going on when we induced the saline and dextrose. We iced the joint, and lo and behold, almost immediately we've got a decrease in that AMI, an improvement in strength of 20%. Now, the clinical implications are that we've created a window in which we can get in and do our quadricep strengthening without the effects of that sensory input leaving the joint and heading into the spinal system and affecting the alpha motor neuron, and hence the muscle not being able to activate. So icing of the knee joint for 20 minutes temporarily reduces the severity of the AMI and allows us to get more effective strengthening, and as a result of that, ultimately we can accelerate that rehabilitation for the individual. Now, in terms of some important points, as I said before, it's important to avoid icing the muscle itself. We've found that partially crushed ice is much more effective than using the cryo cuffs or the cool packs that you might hit, for instance, to bring on coldness. And we've looked at 20 minutes. We've found it's as good as 30 minutes, but we don't know if any shorter would be effective. TENS is another way in which you can create the same window of opportunity, decrease this inhibition, and strengthen the quadriceps more effectively. This is from the work of Pietro Simoni, and what he did was put a TENS device over the knee and then got individuals to do baseline isometric quads activation or strength test, which is what you see here. 20 minutes later, you can see an improvement in torque going on, and 45 minutes of TENS. Again, he's still got an improvement going on there, despite the fact that the joint has fluid in it. And if you're looking for a more permanent result from the similar group of authors, this is where they took a group of people with osteoarthritis and they trained them for 4 weeks. And they did typical training of leg press and knee extensions, step-ups, all the things that you would think of doing with individuals like this. But they added in TENS, and in their experiment, they had placebo TENS. So the TENS machine, the lights were flashing, etc., but it wasn't delivering a real active, if you like, component to it, and the individuals were exercising at the same time at which the TENS machine was on. And then there's a group here that only got exercise. And if you cast your eye across here, look at baseline, look at where the exercise group is, they improve a little bit over those 4 weeks. The placebo group, not much going on there, but we see quite a considerable increase in the peak torque of the quadriceps as a result of this active TENS being able to decrease this AMI that's going on at the knee joint. And for those of you who are interested in the actual parameters associated with it, Pietro Simoni used 20 minutes before and during the training session. These are the current parameters that he used, and he was also making sure that there was as much sensory input but not muscle contraction going into the joint during this time that he had the TENS machine on these individuals. Now, you can also remove some of the sensory output by taking the fluid physically out of the joint, by aspirating it. And this is some of our own work, for instance, from a study where we were involved, or we were working with a rheumatology group, and these people had chronic arthritis and would come in periodically because they had swelling and pain. And in this instance, we aspirated the joint. You can see an immediate improvement in peak torque as we're taking away that excessive pressure in the joint by aspirating it. Day 5 here refers to the fact that at the same time the aspiration occurred, they got a corticosteroid injection, and you can see that would have quietened down the inflammation, and within 5 days again we see a much bigger increase in torque going on in the quadriceps, and by day 15, we see again a 40% improvement compared to baseline. Again, indicative of the corticosteroid being able to lead to an improvement or a decrease in this AMI being active. And my final slide relates to non-steroidal anti-inflammatories. And this was a study by Peterson and co-workers. And essentially, they took a group of individuals and looked firstly at their muscle size of their quadriceps. So that's the red, the cross-sectional area of the quadriceps muscle. They looked at muscle strength as well. And there was one group that got resistance training, which involved 20 sessions of resistance training, and another group that got resistance training with ibuprofen. So we had placebo tablets across here, and we've got the ibuprofen going on here. And the key point to take away here is that you see a really nice increase in the amount of strength as well as cross-sectional area in the group that are getting the real anti-inflammatory compared to the guys in this group that were getting the placebo. So, the take-home messages. Firstly, the key point is that AMI will be present after most joint injuries in the lower limb. Certainly after surgeries where swelling and inflammation occurs as a result of the surgeon's work. And it'll also be present where there is chronic problems where the joint has, for instance, articular cartilage damage, synovitis going on, changes in subchondral bone, etc. Those are situations where you're going to see AMI working. The AMI, the effect is greatest, closest to an acute event, if indeed that's what's led to the AMI, so the surgery again or the injury itself. And in regard to looking after this as clinicians, you've got these options that I've been just talking about. So to work the muscles firstly in an angle or at a joint angle where the intra-articular pressure is lowest, icing and TENS may help to temporarily reverse the AMI, provide that window in which you can get in there and do some training. And then finally, aspiration of the fluid directly, adding some corticosteroid in there, and as you saw in the very last slide, non-steroidal anti-inflammatories are also useful. In closing, I'd like to thank you all for your attention, and I'd like to thank the Swiss Physiotherapy Group for inviting me here and their hospitality. Thank you very much.